This is Healthcare That Clicks, where healthcare, innovation, and big ideas collide. No fluff, just the strategies reshaping the future of care. Here are your hosts, Ryan Kelly and Will Moon.
Welcome to Healthcare That Clicks. I'm Will Moon.
And I'm Ryan Kelly.
Today, we're going to be talking about something that we've kind of been chewing on. So, Medicare created remote patient monitoring or remote physiological monitoring. Physicians were a little slow to adopt in the beginning, and vendors stepped in to fill that gap. And now CMS wants to eliminate the vendor side of things. And so they're not touching on the reason that the gap existed. Today, we're going to dive in a little bit more.
So, Will, I know we've discussed this quite a bit. It came as a little bit of a shock to us as the RPM and RTM have been rolling really smoothly, and we've been encouraging practices to integrate this into what they do on a daily basis. And now with the new CMS fee schedule and them not having third-party vendors being eligible to provide these services, that's a huge setback in remote physiologic and remote therapeutic monitoring, a real concern for us both.
For sure. You missed an opportunity there, Ryan, to do the huge.
Yeah.
So the rule's been out, or the proposed rule rather, has been out for a couple of weeks now. And there's a lot of buzz. And it's been really interesting just to go on LinkedIn and kind of view some of the feedback. And so what I thought it would be good to do is to very quickly just kind of go over some of the changes that they're proposing and why they're proposing it. So we all know with this current administration, fraud, waste, and abuse has been a big focal point. A lot of the administration's, press conferences and talking points that they put out there have been targeted at, identifying bad actors and weeding out fraud within government programs. And so the OIG did a report on remote physiological monitoring from, I want to say it was calendar year 2024, which was the most recent year that they had access to data. And there were some findings on there where, one, they saw a spike in fee-for-service spending. So they launched the program in 2019, and they had 15 million in fee-for-service spending that year. And by 2024, when they analyzed, so 5 years later, it had gone from 15 to 536 million in fee-for-service spending, which you would think would be a good thing, because it means that more patients are being offered services, more monitoring is happening, and especially based on some of the efficacy studies that we've seen, that should mean dollars saved for Medicare. But the stance that they took was a little different. So they found some enrollment issues, and then some of the delivery components that weren't met. Mm-hmm. And when we say enrollment mm-hmm. issues, they never claimed outright fraud. They basically were like, hey, we flagged these patients. Here was our criteria for flagging the patients. We found some instances where things were irregular or abnormal, such as enrollment spikes. Like, for example, there was one practice that they found that had 3,400 new patients in a month. And part of the issue that the OIG report was also exposing was some of these RPM programs did not have prior relationships with patients before they started the program. And I think what a lot of this is doing is exposing and putting a spotlight on bad actors and vendors. Mm-hmm. Because when you look at the gross population that they tested, these bad actors and vendors made up less than 4% of total fee-for-service offerings. So it was a very, very small problem compared to the 96+% of patients that were receiving the service and getting a benefit from it. We see positive metrics in the cost savings. And then to double down on this, the proposed rule for this year, and I kind of went over some of the OIG points, and there's a lot of resources, and there's a whole OIG report. We could probably put out, an explainer on that report, Ryan, but there's lots of resources where you can go dig into more of their findings. But I think the key thing there is that there was no conviction or apparent finding of fraud. There were just flags,
Yeah.
and that was kind of how they talked about them. Was we looked in these areas and we found some flags. So I think there were 10,000 practices that billed for RPM services that year. About half of those met the criteria for the OIG to look at, which meant that they either had 10 or more patients enrolled, or they had billed for 100 or more services in a
Mm-hmm.
year. And of those, the 4,800, 5,000 or so that were screened, there were only 183 total flags found out of those 5,000. The reason that's also significant is one practice could have multiple flags. There were
Mm-hmm.
5 buckets for criteria that they were flagging for. And so when you really look at it, it looks like around 40 or so, 40, 45 practices that had abnormal billing, uh, you know. And
Yeah.
so
And it's like
anyway,
you said, abnormal billing doesn't mean fraud. It could mean fraud, but it also might mean that they brought on a new third party vendor and all these patients that they were wanting to roll into RPM, they rolled all at the same time. There might be just some, what
naturally
you
growing
might call a
problem.
lack of a best practice, but not necessarily anything that wouldn't have taken place anyway had it been spread out more. So yeah, that it's a very small fraction of the number of total RPM and RTM cases. And then let's be real, in every industry throughout the entire country, or I would even argue the entire world, how many industries don't have 3% of the people that are doing some element of fraud, waste, or abuse? It's literally everywhere. And I absolutely believe we should get rid of fraud, waste, and abuse. No question. Will, I know you absolutely agree with that. But
100%.
punishing good actors for the sake of the few bad actors is why we have so much red tape right now in our country. If we could just go after the bad actors and let good actors do what they do because they're doing it the right way, make our life so much easier in every respect, not just with what we're talking about today, but in everything.
Yeah, I totally agree. And I think that's where like some of the solutions that they're proposing are, it's like trying to kill a fly with a cartoon sized sledgehammer. You know what I mean? Like it's not
Good
that big of
analogy.
a problem, but it is a massive, massive solution that they're proposing that could essentially rug
Mhm.
pull an entire industry. Um,
It really is.
so
Literally, it is.
some of the things that they're proposing are one, because this we've already done this and it worked out so well the first time that they're, hey, let's try it again. But they're looking at, should we consolidate all of these RPM codes under a global code, a G code?
Mhm.
And the reason that they started off as a global code, and the reason that they were unbundled was to help, Medicare get a better idea of what specific services were being
Mhm.
offered.
Right.
A lot of the way that the G codes would work in the past is here's a global code and you can bill it up to this many times in a month and it has to cover these services. But it was hard to see like, okay, is this monitoring? Is it communicating with the patient? Is it coordinating with a specialty on their behalf? Or like
Mhm.
what is happening here? So they unbundled the codes. They're proposing to bundle the codes again. Another thing that they're looking at is an initiating visit requirement, which this one's interesting because chronic care management has an initiating visit requirement as well. So this one's not, depending on how they want to define this, if it could be the same as an evaluation of management, like an E&M visit, a regular office visit, or if it could be an AWV or some of these other qualifying initiating visits now for chronic care management, like crosswalking those would make
Mhm.
sense. The way that they've talked about it, it almost sounds like it needs to be its own standalone visit. So let's say you see a patient every few months. Well, you'd have to call them back into the clinic for an office visit to have this RPM initiating visit, is kind of how it's presented. So it's extra step for the provider, extra step of coordination for staff, an extra in-office visit for the patient, which I would argue that a lot of the CCM and RPM programs are meant to do the opposite. It's
Mm-hmm.
meant to provide care outside of the clinic in between visits. We're not trying to constantly drive that patient back into the office.
That's right.
And then finally, what I think is kind of the most heavy-handed aspect of their proposal is the removal of third-party contractors from being able to offer the service. So the way that they're proposing it is saying that the physician practice that furnishes the service, whoever furnishes the service on behalf of that practice has to be a W-2 employee. So they have to work, on behalf of or under that practice. And I'm sure there are plenty of legal workarounds, which we don't have to get too much into. I'm not trying to give Medicare a playbook for how to come out with FAQs that shoot down every idea that we have to work around it. But a good bit of it is just going to put a stop on growth. I'm sure a lot of current programs will figure out how to sustain what they're doing, but because of that added layer, I think it will prohibit a lot of clinics from being able to enter that model just because of the unit economics around it, Ryan.
Mm-hmm.
That's where the OIG report was also helpful in the sense that it exposed the average size of a program. So the average practice offering remote patient monitoring only had 70 enrollees in the program, which is about half of what they need just to break even on a full-time nurse. So how are you offering value if you can't hire somebody and your current staff is already overworked and overloaded?
Yeah. So I was going to ask you that question. How many practices right now have a full-time person or a part-time person that is doing remote physiologic or therapeutic monitoring and not using a third-party vendor? Have you done research on those exact numbers? Or at least an approximation?
I mean, it's really hard to tell. It's really hard to tell. When you look at the publicly available data, you get an idea for, which practices are offering the service. You get an idea for the average size of the program. The best that I've been able to tell is there's a few like outlier practices with a high number of enrollees, and there's a good chance that they're managing it themselves, but they're typically larger health systems.
Yeah, exactly.
I mean, even for perspective, like you've got Community Health Systems, for example, which is a publicly traded company, and they don't even offer their own remote patient monitoring. They outsource to Cadence.
Really?
And so, I mean, that's just one example of, okay, here's a $12 billion a year health system that's listed on the stock market that doesn't even offer their own service because they understand the best way to manage these programs and offer them efficiently at scale is to partner with somebody.
So, well, let's take a second for those who are not familiar with how this works and kind of walk through. And I know, I mean, for transparency's sake, Link does this, and so this is a world you live in. But let's take a look real quick at what a third-party vendor would look like from having a dashboard of all of these different patients and how it's flagged and how that provider who's looking at this day in and day out would be able to see and communicate with these patients. And I know every company is going to be a little bit different, but kind of walk us through a little bit of what that looks like, and that might help to articulate how the value, because I'm biased in liking the third party vendor relationship, but I'm fine with whatever gets the care to the patient. I mean, if I thought that a full-time employee in a facility would work well, then I would absolutely be in favor of that. I just believe in the third party model better. But I want everyone to draw their own conclusions. So kind of walk us through what that looks like from your side or from other vendors that you've seen. And how would that contrast with what an outpatient clinical practice or even a moderate size hospital system might look like?
Yeah. So your typical hurdle is going to be the devices for a practice. And that's why you see a lot of health systems launch RPM where they have outpatient clinics or something, because they can actually support some of the device cost. In the smaller practices, where the vendor comes into play is that, like, we offload that risk from the practice. So most vendors cover the device cost, and it's basically a cost of doing business. Hey, we want to offer the service for you, so we cover the cost. Now there are several vendors out there that don't do that, and it works for them in their markets where they have patients cover the cost, or facilities cover the cost, or sometimes grants cover the cost of the devices. But step one is, hey, we have a population that we want to monitor. And so whenever you're looking at it, it's what problem are we trying to solve here? Are we trying to control blood pressure? Are we trying to control glucose? And then it's a designed program around that. And that's where it's kind of unique to a practice and to a specialty or even to a demographic.
And real quick, by the device, I know these all look a little different, but what is the most common type of device and any peripherals that come with that, just to kind of give people an idea again of the equipment that is being purchased and distributed up front to be able to even launch this?
Yeah, I would say the three most commonly used devices are going to be blood pressure monitoring devices, blood glucose monitoring devices, and weight scales.
Mm-hmm.
Especially with the rise in weight management and GLP-1s. And so, glucose has always been something that's monitored. Blood pressures, it's gotten to where, especially for us, 96% of my patients have hypertension. I mean, it's majority of the primary diagnosis. And so even just blood pressure control has become such a major factor in preventive care and managing health. But every program has a problem that it's trying to solve, and then it's deploying those devices based on that problem. We're trying to control blood pressure, we're trying to lower A1Cs, we're trying to control weight, whatever it may be.
Mm-hmm.
And so there is a real life nurses on the other side of that monitoring. And so devices are deployed, parameters are set, clinical protocols are outlined. What does normal readings look like? What do abnormal readings look like? How are we notified? That sort of thing. And that's where software is beautiful, and that it coordinates and handles the notification process and a lot of the monitoring. And so having adequate software puts that tool in the nurse's hand, and then the nurses, kind of like air traffic control, responding to that dashboard based on the notifications.
Mm-hmm.
So you're either getting readings or you've got missed days of readings.
Mm-hmm.
So if I get a reading, I just need to confirm that I got a reading. If I didn't get a reading that day, maybe I need to call the patient and check in.
Mm-hmm.
And all of these things that are being monitored do several things. They create historical records of vitals so that we can look for trends and get a true baseline for a patient. They help us identify those irregular readings or those abnormal readings where, something's outside of a normal range, and it might be, indicative of a stroke or, something else that could happen later on that we can go ahead and start working preventively towards now, towards that care on. And then the nurse also is communicating with families. So it's not just working with patients whenever they have an odd reading, but it's working with them on the importance of, hey, do you understand your condition? Do you understand why we're monitoring it? Do you understand why it's important to, control your systolic blood pressure, mm-hmm. or to lower your A1C by 2 points? Like, some of it's nursing education, or a good bit of it's nursing education, and then that monitoring aspect. And then it's a care plan and documentation that hands off to a provider. And so every, quarter or every other month or whatever frequency that primary care provider is seeing the patient on, or the specialist is seeing the patient, they're able to look at those historicals and make adjustments to the care plan, mm-hmm. based on the trends that they're seeing and everything else. And so, just the same way that, the pilots, need air traffic control to help them safely land a plane. That's kind of what the RPM nurses do for the doctors. In that scenario, the doctors are the pilots. They're just trying to land the plane. And then the nurses are air traffic control, making sure that everyone gets where they need to safely.
Yep, absolutely. And so all of this goes into care of a patient. And if we're cutting out one of the best tools, and mind you, you and I are located in the state of Mississippi. We were one of the test grounds, one of the chief test grounds to prove the point that RPM works and can substantially reduce A1C and heart disease and the need for glucose monitors and insulin and all these other things for patients, that they can actually become healthier just by a consistent monitoring and coaching and lifestyle adjustment done through this daily RPM. And now, I mean, it's like CMS is doing everything they can to kill the program. Everything you described in their policy workup is what I would do if I were trying to kill a program without officially killing a program. It's one of the best cost savings that CMS has. It's literally pennies on the dollar at best for the savings that they're getting on not having someone on a lifetime of prescription insulin, not having to be on blood glucose monitors, not having heart disease, not getting cancer, not being out of the workforce due to being completely immobilized with chronic obesity, not having knee replacements or back surgeries. The list can go on and on and on of things that CMS, which of course is Medicare largely in this case, will not have to pay for in the future because we're keeping people healthier. So just dollars and cents from the taxpayer standpoint, it's absolutely a program that everyone should be getting on board with. And then from a patient perspective, you're getting that constant care that we all need to have. And then from a physician standpoint, you're getting all the data on your patients and you're able to care for them better. And mind you, you get paid to do that. It's a win-win-win all the way across the board. And for some reason, CMS has decided, oh no, couple bad actors in here, let's kill off the whole program. That makes literally no sense to me at all. And you and I both radically against fraud, waste, and abuse, but that makes absolutely no sense at all. These policies that they put up here.
Where else have you seen a big headline with fraud, waste, and abuse being rooted out in healthcare in the last 9 months?
Oh gosh, I don't know. You're putting me on the spot. I've seen it in several different places. Tell me where your mind's going.
I mean, I was just going to. You've seen it in a few places, but not a lot, and not at the scale that they promised.
Yeah, I mean, that's true. I can't come up with one exact element. I mean, we've looked at it in education some. We've looked at it in, I think banking had something that came up. There's been some.
I can think of for healthcare was the skin subs at the.
Oh yeah, that's true. That was maybe the latest one.
Yeah, Q3 of last year.
And I know we had one with like pain cream and all of that.
Yeah,
and that was a big thing. That was really building more TRICARE, I believe. But
and it takes you back to the days of the diabetic foot baths. Do you remember those?
And there's always things like that, but we're not talking about that. We're talking about a few facilities that, like you said, anomalies, not clearly fraud, but they had 2,000 patients that came on RPM in 1 month, which you and I could both explain a situation that's perfectly legitimate of how that would happen simply by saying, okay, we're going to take all of our patients, we're going to see them, we now identify them as being of a need, and we're going to enroll them all at one time. Probably should have been a scheduled rollout versus everyone at once. So it might trigger a flag, but it doesn't mean there's anything wrong. They were seen, they needed it, they had multiple comorbidities, they were enrolled in a really good program that's going to help them, and maybe they all enrolled at once. But that doesn't mean there was anything wrong with it. They still needed it. There's still patients under that physician. The physician still gets the data, presumably. I think it would be good. I mean, you and I both agree that we are radically underutilizing RPM and RTM in our country. Not like this is something that we got way too many people. It's not like it's, dead people voting here. We're talking like no one is using this that needs it. We need to be 10, 20x the number of people on RPM and RTM right now to really see the full benefit. We don't need to be pulling the rug back. We need to be getting more people to the table and getting them on these programs, because I can promise you CMS can be paying a lot more than $100 a month for the rest of these patients' lives if we don't turn their lifestyle around and get them the help that they need. It's going to cost $1,000 a month, $5,000 a month plus.
All right. That's a good segue. So I got some numbers for you. You ready?
Okay.
All right. So Optum, which, well, I'm sure they're a little partisan, but they put out an actuarial study, and the actuarial study is, I mean, based on the numbers that I see, even a little lower than the reported savings that Medicare has touted for some of these programs. So I do think it's interesting, and I almost think it helps make their point a little bit more that the numbers are lower. But for example, they looked at a few different cohorts: hypertension with complications, diabetes, and chronic kidney disease. And for 12 months of monitoring and reimbursement across these sample populations that they looked at, they found those patients or that cohort with hypertension and complications, they had a medical cost savings on average per member per year of $2,467.
Wow.
For those in the diabetes cohort, it was $3,012.
Wow.
For those in the chronic disease cohort or chronic kidney disease, it was $2,483. Now,
and so run some quick numbers of how much that costs Medicare on that average patient there. How much did Medicare pay for RPM for that patient?
For RPM, I mean, at most they would have paid, half, like $1,000 to $1,400. They spent half of what they saved on the cost savings there to save the other.
That's right.
Those cost savings also translate to preventive hospitalizations or emergency visits. And so I think there's something to be said about that, and you could argue it's a little higher. And I guess some people could say, well, it could be a little lower, but around 30% is a good number. So you enroll a patient in a remote monitoring program. They get extra touch points. They get a personal nurse. They get, this attention and this device, and we see a 30% savings in total cost of care for the course of a year. Yeah. And a lot of what that tool is doing is it's providing a physical thing for that patient to latch onto, and that is kind of their launch pad for a lot of these lifestyle and behavioral changes that they need to make. It's kind of interesting. It almost gamifies it in a way. Patients start taking the blood pressure, and it's like, hey, your average blood pressure is this. We kind of want to get it down on the systolic side. Well, how do I do that? Well, try this, try this, try this. And it's amazing. You talk to them the next month and it's like, hey, have you been trying these things? Yeah. Well, we can tell your readings have improved.
That's right. And there's also an accountability aspect to this too. If you've got a cookie sitting on the counter and you don't really need, you don't need the cookie and you don't necessarily want the cookie, but it's there and you're bored, right? You're going to probably eat that cookie if you don't have any accountability and you just don't care. But if you got to go talk to that nurse practitioner the next day who's checking up on you, and you've got your A1C is going to shoot up and you're going to gain an extra pound, and you got to justify why you ate that cookie, you're probably not going to eat the cookie. And that's one small timely example, but I guarantee you that's literally something that has happened with people on RPM. They didn't want to explain to the person, yes, my blood pressure's up because I really wanted those French fries. And so I ate the French fries with the salt and now my blood pressure's up. They're going to have to explain it and they don't want to explain it. So they're going to eat healthier. Not ideal from a lifestyle standpoint because we want people to own it and adopt it themselves. But sometimes a little accountability is a helpful thing for everybody. And we all need accountability in our lives for a lot of things. So food and lifestyle decisions are not a bad thing to have someone accountable. But guess what? We all mess up. And so someone being on our side and being on our team and helping to coach us through better decisions, better options, how to meal prep, how to get out and exercise, even if it's raining or if it's snowing or if it's whatever the condition is, how to do these things and coaching people through it. That is how you change someone's life. And that is what RPM can do. Yeah. And guess what? We get paid for it too. And so that's where the thing that I know frustrates us all is right now we're talking about how this program and the benefit to doctors and the money. But the money is there and the patient benefit is there, it's a win-win for everyone.
So you asked me earlier what percentage I thought was, a practice's own program versus a vendor-led program. Um, I would base this number on self-reported numbers, and this is looking at self-reported marketing numbers from other people in the space, and just some kind of background info that I get from meeting people at conferences or
Mhm.
groups that have just sold a company or something to get an idea of size. And I'd be willing to wager that 75 to 80% of the remote patient monitoring services being offered today are through a vendor, through
Yeah,
some third party service contract.
yeah. I think those numbers are exactly what I would expect right now. And like you said, the only ones that are not doing it are maybe mid-sized specialty practices that are owning it, and they have a dedicated person and they've got enough volume to be able to handle it. Or you're a major medical center that have very high volume, and you can handle it.
Yep.
There's no rural or critical access hospitals. There's no rural clinics. I'd be very surprised if there were any community health centers that are doing this.
Mm-hmm.
So any small practice, literally, there's no way that they're going to have enough patients coming through the doors to justify a half a FTE, a 3.5, a 0.25 or a 0.75, and certainly not a full FTE's worth of time to monitor these patients. And it's not something you can do just kind of off to the side. You got to have someone who's actually monitoring this, which is why, coming back to my original comment, that I like the third party vendor model, is because you can have someone who is literally dedicated to sitting here and looking at dashboards all day long and talking to these patients all day long and knowing these patients. And even if that's multiple different practices worth of patients all rolled into one dashboard, you still get to know them. And you'll contact them on behalf of Dr. Smith or Dr. Brown or whoever the physician is. You're contacting them on behalf of that physician, but you are an extension of their office caring for their patient and then putting in that data and it going back to the physician for extra treatment. And that might result in extra doctor's visits if there's something they need to do. So it's beneficial to the physician, but also beneficial to that patient. And again, I roll back to the fact beneficial to us as taxpayers because we will be paying less for these patients over the course of their life. They will only get worse. We're talking. You mentioned roughly a 50% savings for versus the cost in the year that was analyzed. Was it Optum? I think you said.
Yeah.
But let's take these patients in the last 20 years of their life. You're going to tell me that that's not going to be multiplied times 20 or 30 with knee surgeries, back surgeries, hip surgeries, the huge number of things, instances of cancer, diabetes, hypertension, all of these things they hit you in those last 10 to 20 years of life. And I guarantee you most of those patients were not even in that sample right there. We're just talking about the most immediate quantifiable savings. Like you said, hedging off hospital visits, hedging off trips to a specialist. All of these things are avoided from CMS by paying for this service and investing in this service.
I'm gonna clip that and use it for sales.
Do it. You go for it. You have my
So
permission.
I think one thing you jarred my memory on, or spurred me to think about, was the fact that you mentioned the community mental or the community health centers,
Mm-hmm.
and a lot of the community health centers in our state and around the country, and just practices in general, with the rural health transformation funding that dropped, built or created a model for RPM, typically in conjunction with a vendor, to use the rural health money to help launch some of those programs and handle some of the device costs that are associated with those programs.
Mm-hmm.
And so, one of the things that the rural health transformation managers like BDO were mentioning at town halls
Mm-hmm.
were the fact that these programs were set up for people to get creative and implement technologies or softwares or different systems or whatever that are models that could help bring access to rural patients or help provide greater levels of care to rural patients. And so I'm kind of curious, like, why why would they push RPM so hard with rural health transformation funding, but then undercut a lot of those programs' ability to offer the service by removing the vendor from the equation?
Yeah, I agree. I agree. Now, certainly one thing that I think we need to, kind of reiterate with this is we are talking about CMS billing codes, which is a lot, is a huge component of what RPM is. It doesn't mean that the service can't be done and other insurers won't pay for it. But most of who we're talking about are of Medicare age and Medicare beneficiaries. And so it is a big component and probably the most vulnerable component that we have here. So it is a huge focal point, and whether good or bad, oftentimes what CMS does, industry follows. So they may set a trend, and that would be a very dangerous trend to be set. I would like to think that insurers are going to see the value in RPM and the cost savings that they personally have. They won't follow that trend. But I certainly wouldn't want to assume that that's the case. Sometimes you don't follow the data, and sometimes you don't um, follow the science. I don't know. I'm not sure if we should say that anymore. But
Follow the
sometimes,
breadcrumbs.
yeah, sometimes we kind of let our emotions or the feelings of the day guide us more than data. And data suggests that RPM and RTM are fantastic investments on everyone's part. And that's the good thing about it. And if it was something that someone lost in the equation, whether it's the taxpayer or the patient or the provider, I would absolutely give pause to it. But I've been such a champion on it for a number of years because it is literally a win all the way around. No one loses in this formula. But I do believe that making it easier for a patient to get on the program, not to the point of fraud, because I could absolutely see if you don't have a relationship with a patient at all, and you're just throwing them on there, like seeing someone at Walmart, and you can clearly see they've got COPD or they are hypertensive, and it's like, hey, give me your name. I'm going to put you on a program, and I'll split some commission with you. Well, yeah, that's absolutely fraud, and should send you to jail, no question. But if they are a patient of a physician and you've done a diagnostic approach with them and you've talked to them and you believe they are a good candidate for this program and it will help them, and this is a prescription of sorts that you order, then yes, they are a perfect candidate. And I believe every physician should be doing that to their patients, and they should be enrolling every patient that would be of benefit to this program. And it should cost a little bit more money because it's going to save us tremendous amounts of money on the backside, save the patient and save the taxpayer a whole lot of money.
Oh
So
yeah.
I can't see a reason to not do that.
And we've talked a good bit about the savings. I know you and I are a little more financially minded, and so that's probably where we lean. But also clinically, there have been tons of studies and efficacy reports that have been put out to show positive clinical outcomes from monitored populations,
Mm-hmm.
and average, like reducing average systolic blood pressures, reduction in high risk diabetes patients, and a lot of the weight monitoring. The way that they essentially target that is number of reduction in readings from critical, or number of reduction in critical readings from weight, where
Mm-hmm.
a patient is gaining weight consistently rather than losing weight.
Yeah.
And so, in those three areas, which I kind of alluded to, were the three biggest are monitored by the kind of three most commonly used devices: that blood pressure monitor, the glucose monitor, and then the weight scale. And so, even just through those three devices, they have been able to show clinical efficacy. And there are more and more devices coming out. There's a ton of use cases for devices that are on the market now, but are not implemented in a program that
Mm-hmm.
could be.
Yeah.
And so, like one example is a like using these programs for medication monitoring.
Mm-hmm.
So now they're starting to come out with more monitoring devices that will hold medications or pills.
Mm-hmm.
And as those are used, it sends a reading. And so it creates kind of a two-way feedback. Instead of just giving patients a traditional 7-day planner, you actually have real-time monitoring feedback on medication adherence, which, as we know, is one of the biggest things that leads to a hospitalization is a non-compliant patient with their medications.
Yep, absolutely. So, one thing I want to kind of pivot to with this is a question that I know you and I talked about a little bit. Why are we so low in the uptick of RPM from the physician side? Why is it if this is such an easy win for the physician and the patient, why do we have so few people that are on remote therapeutic monitor or physiologic monitoring and remote therapeutic monitoring? Why is that from your experience?
One of the things that I like to say is that physicians and physician practices are um, overworked, understaffed, and underpaid. So they already have a mountain of problems that they're dealing with just in regular day-to-day operations, whether with normal E&M visits or lab results or follow-up appointments, or even just think about all of the software solutions in the last decade that have been targeted at reducing no-show rates. Physicians struggle with no-show rates on a daily basis, and so
Mhm.
for the patients that do come in, you've often got large panels per provider so that they can make the numbers work. Patients are only getting a few minutes, with the physician,
Mhm.
and he's doing what he can. But it's a large, like I said, it's a large panel, and so the nursing staff that's there tends to get the brunt of all of the requests and the follow-up calls and everything. And that's where the staff gets bogged down now. Like, you go into the medical office and the front desk phone is always ringing.
Mhm.
Everyone's running around printing papers, going to this exam room, then that exam room, and talking to the doctor, and then talking to a patient. And so you don't have to spend long in a clinic before you can see some of the chaos. And then imagine going to them and saying, hey, with everything that you're doing now,
Mhm.
here's an extra thing that you can do. And if
Mhm.
you do this, we'll pay you this amount. And it adds something to their workflow. And initially the dollars, the reimbursement, didn't make sense, like economically, for them to offer it. And then as it improved, you still ran into the problem of, well, I can't offer another thing. I just can't do one more thing. And that's kind of where vendors stepped in, because it's
Yeah.
like, well, now, like, adoption was low originally, and then
Mhm.
it grew because the reimbursement improved and vendors stepped in and they were like, hey, this would be good for your patients. We can help you offer this.
Mhm.
And so um, more adoption was led, and that's where those numbers from 2019 and 2024 kind of came from. That 15 to 500 plus million um, was that gap that the vendors kind of helped fill.
Yeah.
But you think about what remote patient monitoring is, and how we've described it so far. It would be like a business saying, hey, we're already treading water here, and we can barely keep our head above water. And so why don't we also throw this whole new startup in the mix, and let's
Mhm.
let's start up a new business in the middle of this.
Yeah.
And we're going to need software and devices and logistics, and then technical support and nursing staff. And you start going through all the layers, because your average EHR is not set up for monitoring. So you have to
Yeah.
have a new system. You have to learn this new system. You really need dedicated staff, because, like I said, you go into a clinic, those nurses are dealing with scheduling appointments, or coordinating care, between what the doctor just told that patient they would do and what needs to happen next, or
Mhm.
collecting payments or billing or whatever else, right? And so where is that nurse going to find the time to monitor?
Yeah.
And also the programs need to have a 24/7 component to them, where patient takes a reading or feels off in the middle of the night, and they have someone that they can reach out to, like a true nurse that can triage.
Yeah.
I didn't say it earlier because you don't want to give away too much of how the sauce is made. But like for our remote patient monitoring programs, every patient gets a care team. So
Mhm.
yes, you do have a dedicated nurse who is monitoring and assisting with coaching and lifestyle habits and that sort of thing. But you also get a pharmacist that is going to do medication reviews and a med rec. And I try to identify polypharmacy or areas where we can help patients there. And then we also give patients access to a dietitian, someone that they can work with to improve some of the eating habits that they have.
Mhm.
And one of the things that we've seen from that is get patients off of unnecessary medications or medications that and when we say unnecessary medications, people are like, well, how are they on, real quick, just so everyone knows, if you have an older patient and she goes to this primary care doctor and he puts her on a statin or something and then she gets hospitalized, well, they're not sharing records. And so she's just like, well, here's my bag of stuff, and if she left that medicine out, that doctor's going to put her on a similar medicine.
That's
So
right.
now she leaves the hospital, she's got a new prescription that mimics a prescription she already has. And the only
Yeah.
reason she got the same thing was because she forgot to bring that pill bottle in.
Mhm.
And she didn't remember to self report it because that's how a lot of it happens. Now, there are systems on the back end where you can tap into to see what a patient's taking, but more often than not, that's how it happens. I'm
That's
probably
right.
like exposing the hospitals there.
No, but med
um,
management is such a huge component of what we need to be focusing on. And sometimes I get in trouble by saying this because I give it a blanket, but any patient that's on 5 or more prescription medications likely is taking too many. I can only think of a very small number of reasons why any patient would be on more than 5 prescription medications.
yeah,
Otherwise, you're adding sand to each side of the scale to try to get it to balance, and you're ultimately killing the patient in the process most of the time. Not
hmm
all the time, but most of the time.
yeah, we've seen. I mean, just to give you an idea, we've seen patients on like 15 to 20 different
Oh,
medications.
I've heard stories. And like you said, a lot of them are duplications of the same thing, or one is causing something to go up and the other one to go down
Mm-hmm.
because they saw 3 or 4 different physicians and they're getting the prescription. Sometimes they're calling different offices to get the same prescription filled, or a different prescription, and they're just counterbalancing themselves. And the other providers don't know. So they're trying to tilt the scales because something's off. And so they give another prescription to balance something else out that the other prescription is causing.
Yep.
And
And
they're not laying it all on the table and just starting over from scratch.
And if you're not sending that same medication to the same pharmacy every time, that's kind of the final stopgap, So
The
it's like,
pharmacist.
oh, well, I'm over here. Just send it to that Walgreens. It's close. I'll just go over there.
Mm-hmm.
There's so many layers of the system where there are cracks and things fall through the cracks, and
That's
patients
right.
end up on more
Which,
medicines than
which
they should.
I'm going to try to not get in my soapbox on the benefits of a community pharmacy,
Mhm.
but that's one of them. If you take
Absolutely.
everything to the same pharmacy and that pharmacist who has way more pharmaceutical knowledge than any doctor, and doctors don't like me saying that again, but it is very true. I have had 2 semesters of pharmacology, the same 2 classes that every doctor takes for pharmacology. And guess what? I don't know nearly as much as my friends who are pharmacists and they work in pharmacies and they deal with pharmaceuticals literally all day, every day. The pharmacist is the best person to decide what someone needs to or not does not need to be on. They are literally the stopgap and the ones who should be leading med management, in my opinion.
Yeah, and Medicare or CMS hasn't done many favors to the community pharmacy either
Not
because
at
of the
all. It's been horrible. It's killing them.
yeah, I mean, just because of the reimbursement structures that are there, and then PBMs and their involvement with clawbacks and DIR fees. Your average community pharmacy now, if they don't have a solid, and this is crazy to say, if they don't have a solid Medicaid population, they can't sustain the pharmacy.
I know. You're right. It's got to be
When
heavy commercial or
In
heavy
what
Medicaid.
world did we ever think Medicaid was going to be the thing that propped up a community pharmacy? I
I
mean,
know. You're right. Used to be Medicaid was what drowned them, and now it's the only thing
yeah.
they've got left.
I remember, yeah, 10, 15 years ago, you go in somewhere and they're like, yeah, we don't take Medicaid.
Hmm.
Oh, okay. I
I
got you.
know. Times have changed.
Yeah. for sure.
But the old adage, and this kind of sums up a little bit of what we talked about. If it's good for the patient, the money will follow. We've always kind of heard that, and I do believe for most every instance, it's still true. With barriers, if I were a physician, I wouldn't be giving my cell phone number out and having patients call me at all hours of the night. I think that's horribly bad for the physician. But even if it's good for the patient, it's not good for the physician. But if you treat the patient right and you do what's right by the patient, money will follow. And what we're talking about are really good examples of that. RPM and RTM, I mentioned, annual wellness visits, smoking cessation, obesity therapy and training, sleep evaluations. All of these things have billing codes attached to them. You can make money off of them. Not a lot. Some of them are $10 or $15. But if you're seeing 5 or 6 people a day that are smoking, that ends up being 90 to $100 times 30 days or 28 days. That's not a bad little source of revenue. That can help cover one of the front office staff. These things add up over time. And so to your point, it's like it's adding one more thing to the normal process. And you're exactly right. But now I'm going to roll back into one of our earlier conversations of the podcast, which gets into utilization of AI and AI scribing. Now, if you just build it into your normal conversation about talking about hypertension and obesity and smoking and vaping and all these other things, the AI will catch it. It will auto code in your system and you'll get paid for the things you're just naturally, organically talking about during conversation. And then if you do have someone who is primed for remote physiologic monitoring, it can flag that. It can be something the nurse can follow up with on a regimented process of every patient who's seen, and they might need this process. They could then start to enroll them in it. Now, the problem here is, like you said, no practice like this can afford to add an extra business line and do RPM themselves. And that's where I absolutely believe the handoff to the third-party vendor is critical in that role, because then they'll take the patient, they'll treat them as the patient, an extender of that physician practice, but they'll take care of that patient and data flows back to the physician, which again, in turn, might add extra billable encounters down the road, but it's also making those patients healthier. And mind you, also, if they happen to be in a value-based program for Medicare or Medicaid or commercial insurance, you're making those patients healthier, which is actually reducing the potential of a clawback, and you're increasing your overall revenue. So there's a lot of financial benefits, but what's the missing piece here? The patient is healthier. The patient gets what they need to get from that physician's office. And we turn this back to being a patient-centric healthcare system that happens to benefit the provider in like 80 different ways because they're doing what's right by the patient.
Yeah, you mean patient care rather than sick care?
Exactly. Patient care rather than sick care.
What a novel idea.
I know, right? What we keep talking about.
I think you keep hitting the nail on the head, and that's where it's encouraging for me because I'm in it every day. This is my industry. This is my business, and I know you're very knowledgeable, obviously, within just the healthcare tech space. But the fact that the value proposition is so clear to someone, to like even you who's not in it every day, and like because you're not like I'm sitting around like, okay, I run a business. I've got to think about how to market my business. I've got to make sure that I'm actually offering value so the clients work with me and continue to work with me. And you're not having to ask yourself those same questions, and the value prop is still very clear.
It is.
And I think there's a lot to be said about that from the programs.
Yeah.
I was gonna just add a little footnote here. I found just a little blurb, just a couple of examples of like massive systems that outsource RPM: Providence Health, LifePoint, Community Health Systems, Centera, Unity Point, and Mount Sinai.
Wow.
So these are like some of the largest, except for CHS. I think LifePoint may be public. Those are like massive private institutions, multi-billion-dollar health systems that are still not doing it themselves.
That's right. But I mean, I still point to the small outpatient clinical practices. And we're talking about smaller patient populations, but I mean, how are they, if Mount Sinai can't do it themselves, how is the small rural health clinic on the side of the road going to do that? They're not. They're not going to
Well,
do
I
it.
was
They're
going to
just
say,
not
I mean,
going to serve
the data
the patient.
shows us that they're not. If the
Yeah.
average program right now has got 70 patients or so in it, and maybe it's
Mhm.
gone up, maybe it's 150. You can't, as a standalone practice, you can't sustain an RPM program with just 150 patients.
Yeah, there's no way. And they're already not doing RPM nearly as much as they need to be. They're surely not going to be doing it if we take away the third party vendor option. I mean, there's no, it will be an impossibility for them.
Mm.
So yeah, I think this is just a disastrous proposal. Now, I will say, with the Telehealth Association and the Rural Health Association, we've submitted the comments in response to CMS, and we're also working with our senators to try to get those policies changed. We've had a very good response so far from our elected officials on that. Um, so hopefully this will be a dated podcast, and in the future, near future, those policies will be taken away by CMS. However, the underlying pin here of it needing to be patient centric care that rolls back as a financial benefit to the physician, that stands true. That is absolutely something that our physicians need to understand. This is a value, financial value to themselves, and of personal health value to their patients. And absolutely something that literally every physician should consider doing for their practice. I can't think, I mean, you tell me, Will, is there a type of physician who should not be considering this for their practice? There may be one. Because I know we've talked about a few that are slightly unconventional, and they're doing it for their for their patients.
I mean, uh, it's honestly, it's hard to say. Like, rather than limit it by specialty, I would limit it by the relationship or the frequency that you see the patient. Like,
That's
if you're
right,
only
of
seeing a
course.
patient once a year, you probably don't need to offer a monitoring program.
Yes,
But if
that's
you're
right.
seeing a patient on a consistent basis because you're monitoring a certain condition or a certain aspect of their health, then yeah, like, I think originally they were like, hey, like, we'll design it and primary care will do it. And now we see like the biggest utilizers are really like, cardiology, endocrinology,
Mhm.
gastroenterology. Like, some of the
Yeah.
specialties are the ones that are truly taking advantage of remote patient monitoring.
That's right. And like you said, I mean, it needs to be that physician relationship. That's what this is built on. It's not a machine gun revenue source. That's not what we're trying
Yeah.
to do. It is about building that patient, that a patient centered medical home of sorts. Even if it is among a specialty, cardiologist, that's critical to someone who has heart disease or has hypertension or has a pacemaker for various
Hmm.
heart conditions. That's a critical component to your healthcare system, and they may need to see that. Maybe it's your PCP and your cardiologist and your nephrologist that all need to see it. There's benefit to them having that data and being able to care for you with that data. So I would say from the patient side, if you are obese, if you have heart disease, if you have hypertension, you are diabetic, and you're like, hey, I need someone in my corner, ask your provider about this and say, look, I've heard of this thing called RPM. Do you know what this is? Not the RPM like in a car, that's revolutions per minute. We're talking about remote physiologic monitoring. It is a program where they will come alongside you and monitor your vitals and various lifestyle elements to make sure that you are being as healthy as possible. Ask your provider about that. You initiate it if they're not going to initiate it. And if they're saying no, I don't do that sort of thing, maybe find another provider. Maybe they may not be the right one for you,
Yeah.
because I really believe that good providers are going to adopt this or believe in it and try to find a way to get to their patients.
I agree. And I wish that CMS would propose rules that made it easier for them to adopt rather than harder.
I agree.
Whenever you've seen adoption rise and it's like, hey, now the thing that made the adoption rise, we're going to take that away and y'all are back to figuring it out on your own. That's not where we saw growth. That's not where we saw utilization. That's not where we pull our data for efficacy to show, savings or utilization or improved outcomes. So, And honestly, Ryan, the OIG report that they put out did not call for any of the proposed rule changes or the sweeping changes that they're trying to push. And
Good.
I think even the OIG remedies that they proposed would be a better fit. And we put together a website. If anyone listening would like to go learn a little bit more about kind of the disproportionate response that CMS is taking to this problem, you can go to rpmnumbers.com. And on there, we've got some of the OIG, or the three OIG remedies that they put out there. One was to apply the outlier measures that they already built. So basically, for the flags that they already have, those 5 buckets of flags, whether it's increased, revenue per beneficiary, or a spike in enrollment, or whatever it is, those flags could trigger an audit. That's a good rule. Adding a staffing model modifier to some of the time codes would also help them get an idea for how much is being outsourced versus how much is being handled internally. So, like for the RPM time-based codes where a nurse is communicating with a patient or a family, if those codes had a modifier, then Medicare would be able to know, like, oh, well, this was done contractor, this was done with an employee, which also helps them answer, a little more clearly one of the questions that they have. And then require baseline and discharge outcomes. And so a lot of what we're seeing with other models that they're putting out, kind of like Access, is this outcome aligned payment, where Medicare is starting to signal through other programs, we really, really, really just want to pay for outcomes. And putting some sort of like baseline or some sort of outcome based component to the reimbursement would also help them, accomplish what they want to accomplish, and weed out those bad actors, because the bad actors aren't going to hang around if they have to prove efficacy. They're just in it to make the quick buck.
Yeah. Now, I think those are all really good ideas that will accomplish what CMS is wanting to accomplish without creating extra red tape or backlog in the system. So I really like those, Will. Okay. Well, with
I
that,
can't take credit for them.
I think that's sufficiently.
And I just want it to be known, hey, OIG, good job. Let's do those instead of the rug pull that's being proposed.
Yeah, that's right. Well, Will, I think that sufficiently covers us for this policy issue here. And like I said, hopefully in the future, near future, this will be a non-issue, and this podcast will become dated. But for now, it's a concern of ours because it's such a good program that is under threat. So thank you for the good conversation today. I hope this has been beneficial.
Yeah, the public comment period is open until September 14th. So I'd encourage anyone listening to go and voice your opinion.
Absolutely. Well, Will Moon, thank you for being on. My name is Ryan Kelly. Thank you all for watching Healthcare That Clicks today. We hope that this podcast was helpful. Please go and visit us anytime and all of our other episodes that we have on all of the places that you watch podcasts. Thank you all for being here, and we look forward to the next episode.